Awesome. Good evening, ATE family, and welcome to our first Ask the Expert of 2026. We hope you had a wonderful holiday season and a great start to your new year. Tonight's topic is radiation therapy, and our guest this evening brings a wealth of knowledge and expertise to the table, and we are thrilled to have him here to share his insights. As we delve into an important topic, we will learn what radiation therapy is, its role in the fight against cancer, and how advancements in this field are shaping the future of oncology. If at any time you have questions, please feel free to drop them in the question and answer chat, and I will work them into our conversation to make sure that they get answered. After our call, all registered guests will receive resources from tonight's meeting and a recording from tonight's conversation with the survey link. Your feedback is important to us, so keep an eye out for that email either tomorrow or Friday. So let's kick off this conversation by meeting our guest speaker for the evening, Dr. Curtiland DeVille. Dr. Curtiland DeVille is the medical director of Johns Hopkins Proton Therapy Center, clinical director of radiation oncology at Sibley Memorial Hospital, co-director of the Kimmel Cancer Center Prostate Multidisciplinary Clinic at Sibley Memorial Hospital, and associate professor at the Johns Hopkins School of Medicine. Dr. DeVille is an expert in proton therapy and a leader in several institutional and national clinical trials. He treats geniourology malignancies, including prostate cancer and soft tissue sarcomas, and is dedicated to creating individualized treatment plans for each patient. His research and interests involve better targeting tumors through proton and photon therapies and reducing radiation to healthy tissues. He analyzes toxicity rates with modern radiation techniques and uses the most advanced technology for his patients' care. Dr. DeVille is also a senior editor for Advances in Radiation Oncology, as well as a reviewer for several journals that focus on radiation oncology. He is an expert on physician workforce diversity and widely published in the field. And he is the immediate past chair of the American Society of Radiation Oncology's Committee on Health, Equity, and Diversity and Inclusion, and the current chair of the American Society of Clinical Oncology's Diversity and Oncology Subcommittee. Welcome, Dr. DeVille, and thank you for joining us tonight. But before we dive into our interview, we would love for you to share a fun fact with us, unrelated to your work.
Oh, a fun fact. Wow. And you did tell me that you would ask me that, and I didn't have one prepared. Well, I'm a sports enthusiast and I like soccer, and the World Cup is coming up this summer. So looking forward to a lot of that. And it's a lot of countries this year, so it should be fun. Yeah.
Well, that's good to hear. I too enjoy soccer or football, as some people might call it, and
Exactly.
I thoroughly enjoy the sport. So thank you for sharing that with us. We wanted to just get to know you a little better. And so as we dive into this topic, I think we should first start by just an explanation. What is radiation therapy and what is its relation to treating cancer?
Okay, well, radiation is a specific form of energy that we can use to treat cancer patients. We can also use for disc diagnostic imaging. So many people may be kind of more familiar with that and getting x-rays or CAT scans early on. You break a bone or you have a fall or you have a cold or cough or those sorts of things. And sometimes to take a step back even more, I kind of tell patients, radiation's all around us, right? You're out in the sun, there's radiation energy, you're out in the microwave, radio waves, all of this is energy. And radiation that we think of therapeutically is what we call ionizing radiation. So it's a specific portion of that electromagnetic spectrum that is when you deliver radiation, it can actually be used to target at a tumor or at a site and cause DNA damage for cells that are dividing. And cancer cells are often dividing, they're trying to grow and spread. And so that's a way that we can sort of manipulate and harness this radiation energy to our benefit and actually treat cancer.
And I know you mentioned that radiation is all around us. How do you differentiate that radiation between like what's good from a microwave? Because I've heard people kind of say microwave radiation is bad for you. How is that not bad, but maybe the one that we use for cancer is a little bit more focused? What's that difference?
Yeah, no, so we've learned over time. I mean, this is like radiation has actually been around for over 100 years. When we think about, Marie Curie and people who were working very early on and figuring out that radiation actually, that was there sort of this energy that had these properties. And so there was, long, long decades and, I guess more than a century now of understanding how we can use and manipulate, and specifically what we call ionizing radiation that creates DNA damage. There are other forms of, energy, radio waves, microwaves, those that have other properties and other things that we use to take advantage of, but don't necessarily have, or in the sort of classic way we're thinking, kind of this therapeutic benefit to treat cancer. So it's not that you have to sort of go, I don't want folks to take away and sort of be afraid of like, oh my goodness, there's radiation all around us and that may cause us harm. I think we just sort of learn and understand over time how we use different forms of energy. And specifically, when we think medically about what we call radiation energy, is what we specifically say ionizing radiation that can create DNA damage.
So when we're talking about creating this DNA damage in terms of cancer, how is radiation different from like chemotherapy or actually like the removal of the tumor via surgery?
So yeah, we can think of radiation. I would say the big three main categories we think of surgery. When we're treating cancer, we think of surgery, we think of chemotherapy, and we think of radiation. Chemotherapy or systemic therapy might be the more general category, the treatments that might be administered with a pill or an injection, and they kind of work through your whole system. Radiation, we think of maybe more like surgery, where it's often more focused and directed and sort of a local therapy in that sense. And so the impact is more on what we're targeting, and sort of the side effects are also going to be on what we're targeting. And ultimately, when we see a patient with cancer and are thinking about their cancer and what treatments they respond to, different cancers respond to different types of treatment. And so there are some types of cancers where radiation plays a primary role, like prostate cancer, for example, where I treat, where you could have the patient might be eligible for surgery or eligible for radiation, and their outcomes can be equal. Or there are other cancers where radiation is what we would call like an adjunct. It's done in addition to other treatment. And, for example, for like a brain tumor or sarcoma, you mentioned one of the other cancers that I treat, which are cancers of the soft tissues of the body. Their radiation usually plays a secondary role. The patient's outcomes are best if they can have surgery, and radiation is helping to reduce the chance of cancer coming back. So, sort of cleaning up any residual cells that might be left behind. And it may also be used in combination with chemotherapy as well for certain types of cancers, where the patient might need multiple treatments. They may need surgery and chemo and radiation to try to reduce risk of spread, reduce risk of it coming back in the same place. So each, I think, as patients are sort of working through their diagnosis, they may encounter that these different recommendations are being made depending on where their cancer is located, what the risks are, and whether they might need multiple treatments and whether radiation by itself is an option or not. Sorry.
Oh, that's great. And so like when we talk about the different needs like chemo or radiation or surgery, when it comes specifically to radiation, are there different types of radiation? And if so, how do you determine which one is right for a particular patient?
So there are different forms of radiation. I mean, in the classic sense, we think of external radiation. You can have radiation that's delivered externally, like X-rays. So if people have had an X-ray or a CAT scan, I tell the patient it's quite similar to their setup there, except rather than using a low dose of radiation energy to take a sort of broad picture, we're using a high dose at a very targeted or focal spot. And so that may be, that's kind of more classic. And then we can also use internal radiation where we're implanting radiation in the body. And that may be something with, it's called brachytherapy. And that may be like a seed implant where you can implant radiation in the body. And so again, it's very much dependent on the type of cancer one has and whether they may be eligible. Excuse me, if you give me 1 second, I'm gonna handle the barking in the background. Just give me 1 second. Sorry.
No worries. And don't forget to use the question and answer feature if anybody has any questions, okay? And you can drop them at any time.
Sorry about that.
No worries at all. So does the staging of a person's disease, does that influence whether radiation is an option for them or not?
Yeah, it does. And so, again, it may be very different depending on the type of cancer. So, just kind of to work it through it from a patient's perspective, they may have had some workup, they had a biopsy, which is sort of sampling of that body part, say it's the lung or the breast or the prostate. They confirm that there's cancer. The next part we call staging is where we get a set of imaging studies or other testing and workup to try to get a sense of where's the cancer located. Is it still localized to where it started, or has it begun to spread? And that, because that's the ultimate risk with cancer, right? There's sort of cells that are growing uncontrollably and ultimately have the potential to invade locally or spread distantly. So we want to get a sense of what's going on. And so that's where we sort of stage the patient. Is it localized? Is it regional spread? Or is it distant spread? Patients that have distant spread are most often in most cancers are going to go a systemic route, or systemic treatments that can work through the system are going to play a primary role. And that's because it spreads through the system. So you have to do that. Radiation can play a role in metastatic or cancer that spread. I can sort of come back to that. But more often, in terms of curative treatment, it's going to be for early stage cancers where it has not spread, and we're defining a local therapy to go after the cancer.
Okay. And you were mentioning how it could be used for metastatic disease. In what case would that be an option?
So that's going to be if the cancer might be causing symptoms, and we're using it for what we call palliation or palliative treatment, so pain control. If you have, for example, prostate cancer that's spread to the bone, you may use it to target that area in the bone and relieve pain. And it's very effective in that setting as well. Yeah.
Well, wow, I definitely didn't know that radiation can be used for palliative care. That's very interesting. And so with that being said, what are some, before we dive into like personal kind of questions about radiation therapy and patient experience, what are some of the upcoming or recent advancements in radiation therapy that patients can look forward to, or that are really trying to change the outcomes for patients as we look forward?
Probably a few things I can say. I mean, fortunately, our imaging targeting technology, things are becoming more advanced. I mean, you can, look around and see technology in all of our lives is always advancing. That's a good part about radiation. We call it kind of the therapeutic ratio. It's like getting more dose to the tumor or better protecting the surrounding tissues, and ideally doing both. And most of our radiation treatments are continuously doing that. So when I talked about delivering external X-ray radiation, we're doing that much better and more safely nowadays compared to what we did 10, 20, 30 years ago. And also a better safety profile. So we're having less side effects and patients can tolerate treatments better.
Oh, that's so good to hear. And one question to piggyback off, and this is a question from me, but when we talk about just regular radiation therapy, what is the difference when we talk about proton therapy? As we were reading your bio, proton therapy was popping up. So how is that different than traditional radiation therapy?
So proton therapy, there are only like 40 some proton centers in the country. So it's been around for a while, but we're sort of growing in the number of centers and the experience that we have. The benefit, it's delivered very similar to X-ray or more classic external radiation that I talked about. The difference is there's no exit dose into the surrounding tissue. So when we deliver the radiation treatment, it hits the target, the beam stops. And so we can better protect the surroundings. Sometimes patients say to me, oh, the collateral damage or the collateral exposure. We can better protect sort of what's outside of the target delivering it. Now, it's not to say that one treatment is inherently better than the other. I kind of tell patients, we have a variety of tools, and we're going to sort of figure out what tool is most appropriate for your cancer in the right scenario to determine whether you're a good candidate for that particular therapy, whether it's proton or X-ray radiation.
Okay, we have a quick question from the chat that's relevant. It says some folks talk about cobalt therapy. Is this radiation therapy, and is it used anymore in the US?
What was it again? Maybe I can see it in the chat. Oh,
Cobalt therapy?
cobalt. Yeah.
Yeah.
Cobalt, yeah. So cobalt's still used. Cobalt has a long historical history where it was, it's when you have an active radiation source that was put into the machine, and then you sort of open, you're sort of shielding it, and then you open it and expose radiation. So you kind of have this active source. So there's a lot of radiation safety protocol around it, and it's not necessarily ideal for a traditional linear or traditional machines that we have for radiation. Globally, it's still used. There are many countries, sort of lower middle income, the cost, there can be sort of benefits or advantages in that way. But there are other machines that still use cobalt sources of technology. There's something called Gamma Knife, which is a radiosurgery or targeted brain radiation that we can use that technically uses that as a source. And now there's what's called an MRI LINAC. So it's a machine, an MRI machine used to deliver radiation that takes advantage of that. So it kind of depends, where that person may have heard of that in the context under to really understand, where it might be beneficial.
Okay. Now, is it something that's offered, or is that something that usually is kind of shied away from nowadays? The cold.
It's not, again, in the context of if they were talking about Gamma Knife or MR-Linac or something like that, it's a standard therapy. Otherwise, in the US, you're not going to find a cobalt linear accelerator.
Okay.
But they may have been, somebody may have mentioned cobalt in the context of those other machines, then which would be appropriate.
Okay. And so, walk me through. I'm a patient and newly diagnosed, and radiation therapy is what's suggested for me or recommended for me. What could I expect during that preparation phase and like throughout my course of radiation?
Yeah, so we see the patient in consultation. The next step, usually, if we're going to do radiation treatment, is to do what we call a simulation session, where they get a planning CAT scan. We're brought into the department, they're brought into the room, and we put them in the treatment position. We may make some, because the goal is to have them set up the same position every day. So you may put them in immobilization devices, a vacuum bag, arms up, whatever, depending on the site we're treating. So that's kind of a long session that they'll have with us, maybe booked for an hour and a half. Sometimes people call it the mapping or something like that. Then they'll go home and I tell them we're working on the plan. It may take us a week or two to turn around and create the plan. While we're doing that, the physicians working with the physicists and the dosimetrists, people sort of behind the scenes who are helping delineate basically what do we want to target, what do we want to protect, how are we going to deliver the radiation there safely. And so once that plan is created, the patient will come back and start their daily treatment. Most radiation courses, will run for a couple of weeks. They used to be very long courses, like 6, 7, 8 weeks daily, Monday through Friday treatment. I tell the patient they're in the department for an hour. The treatment's 30 minutes, and the treatment slots are 30 minutes, 20 to 30 minutes, and the treatment itself is 5, 10 minutes. But nowadays, we can get through radiation faster often because our imaging targeting technology is better. They may make it through the treatment in maybe a week or 2 weeks even. They're faster courses that we can get through more safely.
That's so good to know, because sometimes there's a misconception that there's not a urgency on the provider's behalf to kind of get things started, and to know that you have to kind of coordinate specific things and create this individualized plan. That's very important information, because it kind of can help set the expectation of the patient, and not think that the doctor is kind of just putting them to the wayside. And so
Yeah, no,
with this, oh, go
it's
ahead.
very important. No, I appreciate you for saying that.
No worries, because you're right. I think sometimes we just when you're operating in your individual world, it's hard to fathom somebody that has to oversee multiple worlds. And so sometimes you feel like you're just getting pushed to the side. So I'm glad that we were able to put that on this call this evening. And so when we're talking about being a potential patient, this comes from the chat. Are there parts of my body that I cannot or I should not get radiation therapy on? And if it's true, what would we do instead?
Not really. I mean, we can really treat from head to toe, across the entire body. It's really certain areas are more sensitive to radiation, so it's tougher to deliver or there may be more side effects. For example, I'm treating the prostate. Sometimes patients will ask me, am I going to have a bad skin reaction? And I'll say, no, we're treating deep in the pelvis. it's you don't get much skin reaction. Unlike, I'll ask them, if you know someone that had breast cancer, radiation for breast cancer or head and neck cancer, where the skin is in the target, we expect them to have a skin reaction. So these are sort of expected side effects. The side effects are limited to the area we treat. And again, some areas are more sensitive. Kind of I sort of explain to the patient, starting at the pelvis and going up, the pelvis can tolerate high doses of radiation. As you get up higher, the tissues are more sensitive, the bowel, the liver, the kidney, and then our pink mucous membranes, the oral cavity, taste. These things are very sensitive to even low doses of radiation. And so that's where you may see more side effects, or treatments are kind of harder to tolerate in that sense. But it's not really that we can't treat any particular site in the body. It's really just sort of more, is it appropriate or not to treat? Yeah.
And so you started touching on side effects, which is perfect. That leads right into my next question. What are the common side effects of radiation therapy? And then what are some of the management techniques for that patient dealing with side effects?
So yeah, side effects, is a complicated conversation in the sense that again, it's limited, it's specific to what we're treating. So, really it's going to be side effects associated if we're treating the oral cavity. It may be taste and inflammation, irritation, things like feeling like a sore throat, that sort of thing. If it's breast cancer, it may be the skin that seems like a bad sunburn, peeling, breakdown. But there are temporary side effects that we expect during treatment, and then there's that go away afterwards. And then there's kind of rarer, potentially more severe side effects that can be more long term. And like for prostate cancer, we may talk about the risk of rectal bleeding. So not so much of a smaller risk during treatment, but 2, 3 years down the road, even in a patient that didn't have any symptoms, they may notice some blood in the stool, blood in the tissue, and then we think it's hemorrhoids. It's not hemorrhoids. We do a colonoscopy or something, and we see, oh, this is an area of radiation irritation that just didn't heal well and only manifested a couple years down the road. And we can treat and manage and do things like that. But those are like rare, severe risks that we talk about, like 1 to 3% when I'm consenting a patient and reviewing, all of those risks with them. That, say, unfortunately, despite our best efforts, sometimes we still may notice some of these things. So I think the key for patients is, when they're meeting with their cancer team, their oncologist and the radiation oncologist specifically, just to get a good sense of, and hopefully most of us will have good materials that are written about this in our societies. There's a lot of good patient education material on this, but that they are very much specific to the area we're treating, and just have a good understanding of what can I expect during my course of radiation. And then long term, even if I get through well, what are the risks? Because a lot of time I think patients are surprised about that. Oh, I had no side effects during treatment, but yet I'm still at risk for things down the road. Yeah.
Yeah, that's so good today, especially as you were talking about how treatment time is getting shorter. Getting treated in a week or two, and noticing, positive side effects, not side effects, but positive, shrinkage or response. That's the word I was looking for, a positive response. I think that, you don't realize that, hey, there's stuff that could still happen later down the road. And so when we talk about let's talk about like some of the soft palates. You said as we come up into the abdominal cavity, maybe our oral cavity. Let's talk about the mouth, head and neck cancers. Um, what are some of the techniques that are used to kind of combat the effects of like the treat, like, sore throat or the loss of taste? Is there anything that is done to kind of help that?
No, that's a good point and good question. I mean, we see patients weekly during treatment. It's a standard practice, every 5 treatments or more often, to check in with the patient and check in on their side effects. And, radiation side effects can be predictable in the sense of the first week, not much is going on. Second and third week, I'm seeing these changes. And so we can make recommendations, for example, things that help to reduce secretions if the person's getting thick secretions that are uncomfortable. If they're getting some soreness, we have a solution that's called magic mouthwash that they can use. So yeah, it's really, or even just taking anti-inflammatories to reduce pain, Tylenol, whatever. It's kind of, sometimes I tell people, it's kind of like having a cold or a flu, right? Like, you have some symptoms that are going to come, and you just need to manage those symptoms and get through it, get to the other side,
Yes.
And so for something like prostate cancer, if their urination is getting more frequent or urgent, we have medications that we might prescribe to just help them get through, things like that. Now, there are more severe scenarios where, like, if the person's not eating for something like a head and neck cancer or an esophageal cancer or something like that, they may need a feeding tube, and there's sort of risk like that known ahead of time that might be counseled on. Like, so, some treatments may be, we have to be very proactive about more severe risks to help patients get to the other side compared to others. Yeah.
Understood. Now, if I have more complications during treatment, does that increase my risk of complications after treatment?
Not necessarily. In fact, they're sort of completely different process. Acute, they're sort of expected, more common, inflammation, irritation kind of goes away. Those may not be tied, and in fact aren't. One of the things with radiation, sometimes people ask me, like, okay, why do you get the weekends and holidays off? These were studies that were done long ago where they gave, a break with the weekend and the holiday. Really, the weekend is to allow for normal tissue repair and healing. So the reason we only treat Monday to Friday and you get the Saturday, Sunday off is that the studies have shown that allows for the normal tissues to repair themselves. Cancer cells aren't good at repair. They're not sort of worried about repairing themselves, just about dividing. They don't have good repair mechanisms. And so that's why there's sort of this built-in break process. And these come from historical studies where they treated, for example, lung cancer, and they treated like every day without a break. The patient, you killed a lot of cancer, but you killed a lot of normal healthy tissue.
Right.
So they realized you need a break. Well, then they did the opposite for in like pancreatic cancer. They treated, gave a break. They called it split course. Treated, gave a break, and then treated again. They gave like a 2 week break. When then they saw there was a lot of recurrence. It was actually you gave too long a break, and now some of those cancer cells did,
Have it.
kind of progress. So there is the right balance of allowing for some normal. And patients will tell me that, like, oh yeah, I had my weekend, I was feeling better. By Monday, you're getting, then by Friday, okay, I'm feeling a little bit more tired. I feel those effects adding up. The weekend helps. So they even sort of notice it themselves that is actually, that process is actually happening. Yeah.
Okay. And so when we talk about specific cancers, because I know we've kind of pulled oral cancer, prostate cancer, but when we're talking about specific cancers, is there ever a particular benefit to like a particular cancer where radiation therapy is like, this is the go-to, or is it generally applicable for all cancers or most cancers, I should say?
I would say radiation plays a role in a large majority of cancers. Maybe that's my bias as a radiation oncologist, but at the same time, we can think of this concept of like radiosensitivity. There are some cancers that are very sensitive to radiation. There are others that are not as much. So something like lymphoma or squamous cell cancers, which include, things of like the head and neck or the esophagus or sort of others that it's the cervical cancer, that they are very sensitive to radiation treatment. Then there's other tumors like melanoma, kidney cancer is one that I treat as well, which historically are thought to be less radiation sensitive, and they take really high doses of radiation to see a response, whereas something like lymphoma, you could give a very low dose and see a lot of response from. Um, but at the same time, you may, just because it's not sort of, it takes more dose or it responds more slowly, it doesn't, it can still be beneficial. And so it really is just more about where do we have the best evidence and outcomes. And so, like I gave the example for prostate cancer, you can have a cure with surgery or you can have a cure with radiation. And then it's about figuring out what's the best treatment for this patient in front of you, their age, their health status. Certain things might steer us in one direction versus another. Um, in other scenarios, like I mentioned, well, for breast cancer, brain tumors, those are ones where surgery plays the primary role, and radiation plays more of this adjunct or supportive role of just sort of cleaning up residual cancer cells, reducing the risk of cancer coming back. And so it's sort of not an all or none. It really is just sort of figuring out, and really hopefully not that complicated, just as you're sitting with an oncologist and kind of going through the treatment algorithm. Now, I will say it's always fair to ask. I see many patients who say, "Oh, no one ever told me radiation was an option. I sort of had to find it myself. I had to look it up myself," or things like that. So it's important, I think, for patients to ask because they may start only with a surgeon, right? Or they may start only with an oncologist and not know, hey, is surgery an option here? Is radiation or other invasive interventions? There's things that interventional radiologists do. There's a lot of new different therapies, cryoablation, things that may fall, outside of the traditional scope that we think of just surgery, radiation, and chemo. So I think just kind of asking, are there other options? What are the alternatives? is always a fair question. And I'm happy to receive that. I could tell the patient, I'm not going to kind of explicitly tell you the details about surgery, but I can, kind of be able to tell you whether you're a candidate or not. And yes, we have some great surgeons. Let me connect you with them to kind of see, or we'll discuss with them in a multidisciplinary fashion, as we should with most types of cancers, to really make sure the patient is being offered the best treatment options.
Okay, so you mentioned earlier about some of the cancers, like kidney cancer, aren't as sensitive to radiation. Is this a case where we might go with chemo to help potentiate the radiation?
Well, in that case, a little bit different. There are some actually, the idea of potentiate, so there are certain cancers that respond well to both chemo and radiation. And actually, when you use them together, you get even better, even more response. So, squamous cell cancers that I mentioned before
Mm.
fall into that example. And so it's very common for the treatment regimen for a head and neck patient, for an esophageal patient, lung cancer patient. Excuse me, they're usually often getting these combination therapies. Bladder cancers in the urologic cancer spectrum that I treat. Bladder cancer is one where we do usually do chemo and radiation together, or targeted therapy, some of the newer systemic therapies that have come out, to essentially induce more cell kill, kind of get more success in terms of being able to eliminate the cancer or shrink those tumors. There is some which you kind of might have been getting at, where some scenarios where we use radiation and chemo and radiation up front to try to shrink the tumor bound to make it more likely to be resectable. So for something like pancreatic cancer, where the tumor is felt to be unresectable or borderline resectable, things like that, where we're doing treatment up front, and this may happen with sarcoma as well, where we're doing treatment up front together to try to improve that risk, or to also reduce the risk of cancer spreading while you're delivering the local therapy. So chemotherapy, systemic therapy can work together in combination well with radiation treatment, in certain scenarios in that way. And actually, just sort of a plug for proton therapy. There's actually a large study that was published a few years ago by the Penn Group. Before I joined Hopkins, I was at the University of Penn, and they looked at the early experience of over 1,000 patients who had been treated with chemotherapy and radiation together. And their patients who received the proton therapy, because there was less collateral dose exposure. They actually looked at, the interesting outcome was the rate of an unplanned hospitalization within 90 days. And the patients who had received protons were less likely to have an unplanned hospitalization, given that they were able to tolerate the treatment, their blood counts, were better preserved, were sort of spraying less radiation dose around. So that's where there are certain unique scenarios where we may see, if I see a sarcoma patient, for example, who's getting systemic therapy, I need to go after a local tumor target that's progressing. That's where I might consider, oh, we'll get an added benefit of protons, might be that we're going to be able to keep on their systemic therapy while going after this area, and they're going to be able to tolerate treatment better. Yeah.
That's good to know. And while
Mhm.
we're here, I'm gonna stop and get a couple questions out of the chat. So one says, is it dangerous for certain individuals, like pregnant patients, to be in close proximity to patients receiving radiation therapy?
It's a good question. It's one that we get often, and that really only has to do with implanted radiation in the body. Those are what I call brachytherapy, is that category of radiation. So we have internal versus external. When patients get external radiation, they can be assured that I tell them the only time your radiation's in your body is when everybody steps out the room and they turn the beam on, the beam passes through, turn the beam off, everybody comes back in the room. They could scan, survey, there's no radiation activity anymore. Now, when we do implanted radiation, if you put prostate seeds in, which is kind of done, it's not a surgery, but I explained to men, it's kind of how their biopsy was done. They might have had an ultrasound probe in the rectum, and then needles were guided through the skin and deposited radioactive seeds. Oh, well, snips were taken to get the biopsy tissue for seeds. We just implant the seeds that way, and those stay in permanently and decay over time. And such that, after a few days, in sort of month, even, if you were to scan them, you're not really going to detect significant radiation, but early on you would. And so in those cases, patients are given precautions around things like don't, stand next to a pregnant woman. Don't be within sort of 3 feet or have small children in your lap or adjacent or things like that. And actually, I forgot to mention before, there is what's called radiopharmaceutical therapy. It's a growing area where sometimes I call it to patients like liquid radiation, where we do infusions that are radioactive material. So we have for nuclear medicine, we have radioactive PET scans or tracers that have been developed that help us to identify as you patient gets an injection, you scan their body and you sort of see where the cancer cells have spread to. Well, so now we figured out how to tag or add radiation treatment to that. So we can use an alpha particle, a beta emitter, things like that. So there's treatments called lutetium or radium 223 that we do as well in our clinic. And so when we give that infusion to the patient, they are actually radioactive and they're also given precautions around, okay, now when you go home or on your way home, you have to, for this amount of time, for 3 days, you can't have people within a certain amount of feet of you. And this is how you handle any bodily fluids or things that you're disposing of. So there's a whole set of instructions that they'll get. There's actually a lot of commercials people may see these days on these kind of treatments. And so it can be challenging for a patient to really, the treatment itself is well tolerated, but then now how do they manage this radiation safety protocol at home? So again, that's pretty niche. The average patient that gets radiation doesn't have to worry about exposure, but any implanted radiation in the body, that's where there's going to be something like that. I do think I see a lot of patients where it feels like maybe I don't say like ostracized or stigma. There's something where people are sort of being overly precautious. They think somehow they're at danger because this person's getting daily radiation treatment, and they say, no, this is not that kind of case. I even have patients ask me, sort of, I treat prostate cancer, and so they're asking about sexual intercourse. Is it safe is there a risk of transmission or exposure or something like that? And I can assure them from, with external radiation, there's no risk to the partner, the spouse, or things like that. However, if they had the prostate seeds, they're going to be given some information on that and told, for example, to use a condom, a barrier method for the a certain period of time in case, there's a seed migration or something, just to minimize risks of radiation exposure. But the average patient coming for external radiation, that's not something they need to worry about.
That's very interesting because it's not something that you would necessarily think about, but I can see how that could impact somebody's quality of life and somebody's kind of like adherence to being successful in their journey. And so
Yeah.
this leads me into kind of like misconceptions that we have about radiation therapy and among the general public. Um, what are some of the common misconceptions aside from thinking that an external radiated person is radioactive? But what are some of those similar misconceptions that we as the public might carry around with us that we can debunk right now?
Oh yeah, there's a lot. There's so many just popping in my head as you're talking. I think, some of the common and maybe more major things people don't realize radiation can be a cure, that we're going for cure. Can be a curative treatment and success rates can be very high. And the downside of the damage and the risks can be very low for the majority of patients, which is a good thing, right? Like we're living longer, we're killing more cancer, but we're also worried about the other side, that quality of life, function, having, good preservation of outcomes. So I would think, and that was something as I was sort of early on in training, I was like surprised where people, sort of lay like, oh, they use radiation and you can still cure patients. And, this guy like, oh yeah, it's still an important, something like half to two-thirds or more of cancer patients will receive radiation treatment along their course. So it's kind of an integral and vital, and it's actually a highly cost effective in terms of, thinking about our healthcare system and healthcare delivery, the fact that patients are cured or that you have very good outcomes and control disease for long periods of time, and it's a pretty efficient, effectively delivered treatment. And so I think there's a lot of positives from that sense. The complications, I think sometimes there may be people don't realize, yeah, radiation effects are targeted or focal, local. they may think of it more just sort of group chemo and radiation together. And often because sometimes they were given together, maybe they knew a friend or a family member, and they just, they didn't necessarily tease out what was chemo, what was radiation. So when they're coming for radiation, they have a very different picture of
Right.
or sort of the imagination because that's just what they knew. And they say, okay, no, that was. I'll often ask patients, I can tell sort of from the way they're asking me, I say, okay, did you know somebody or what type of radiation or how long ago was it or things like that, just to get, okay, no, your treatment would be very different. You would not lose the hair on your head, for example, if we're treating your prostate, but people, people don't necessarily know that because they may just sort of group like, oh, I heard chemo, you're nauseous, you vomit. You're like, well, no, if we're treating your prostate, we're not going to expect those kind of symptoms. If we're treating your upper abdomen, then okay, you may have some nausea, vomiting, diarrhea, things like that, which we can manage those symptoms. So I think that's the idea that also the side effects are sort of localized and not systemic when we're giving targeted radiation. Um, I think those are some of the main ones. There are probably a lot of others that will
I
come to
have
me
one in the
with. Oh,
chat.
go
I
ahead,
have
go
one
ahead.
in the
Yeah,
chat that I
yeah.
think that might be helpful. It says, is it true that the same area of the body cannot be radiated again? And if it is true,
Yeah.
does this pertain to areas that maybe have been treated years ago?
Yeah, so it's not true. Like we say never. In general, it's not necessarily common to retreat the same area. Um, but it can be, it always depends on the situation. So for example, for prostate cancer, um, we generally for most cancers, especially if we're doing it in a curative and like the person's only getting radiation, like we're maxing out. We're giving like as much radiation we can safely to try to kill the cancer within the prostate, but we also have to, we have to sort of limit the dose to the rectum and the bladder. Those are really what are going to impact the limit of radiation that you can give. But to the point of the question that was asked, the person that asked it, if someone's cancer comes back, maybe it's been a couple of years, it's only in that area. One of the treatments we can do is retreat the focus of cancer with more radiation, so they can get sort of repeat radiation, but we do have to, we may counsel them. There's higher risks of more side effects or complications or something, but it's worth it because if that's that's still the safest profile treatment or things like that, it may be an appropriate indication to sort of repeat radiation. The other scenario is in that palliative treatment that I mentioned, early on. If we see a cancer patient, maybe it's a cancer, metastatic lung cancer that spread to the bone, and they had some good pain relief. They're doing well on their systemic therapy. A year or something passes. Now that same area is kind of coming back, causing some pain. We can usually give more radiation dose to that same area. Now, a third and a fourth, and like there, we're usually probably going to run out. We're going to at some point reach a limit. But it usually, in that sense, it kind of also sort of means maybe we should be thinking about other treatments if it's coming back after like multiple courses of radiation. So we kind of never say never, but most often people are not receiving radiation, but it is possible to receive it. And it's, kind of case by case review of like what's the appropriate treatment in this setting.
Good to
Yeah.
know.
Yeah.
And so, as we're on a community call, and
Yeah.
we're coming towards the end of our time, but as we're on a community call, how can communities better support patients undergoing radiation therapy? And I'm going to add also the education behind what radiation therapy is so that we can kind of demystify some of the I feel like we've lumped all cancer treatment into one group. You hear cancer, like you said, you're going to lose your hair, this is going to happen. They kind of cancer is depicted on our media in one certain way. So what can communities do, one, to better support people undergoing radiation therapy, family members, a partner, and then how can we better educate ourselves and those around us?
Yeah, no, that's great. I mean, to answer the last one quickly, there are some great resources. Our Society for Radiation Oncology, ASTRO, American Society of Radiation Oncology, has a something called RT Answers. If you sort of just Google RT Answers,
I'll be sharing it with you guys.
good. Yeah, they have a number of, it's designed and targeted for the patient of like explaining the radiation A to Z, like hopefully I was, sort of trying to do. But you can sort of hone in on specific types of cancers and, that sort of thing. American Cancer Society has, some great resources. Hopkins, website has great resources by department. So definitely look at those, peruse those. Sometimes for the patient themselves, they may be overwhelmed. That's why I think the family, the caregivers, the community, like you're mentioning, like, that's where people can provide support, good resources, trusted resources, not the Dr. Google, but like, what is good evidence-based and just non-biased materials, so I think that's where we as, family members and friends and whatever can provide, try to help people with that because there's a lot of, information in there that unfortunately sometimes, it's just not great, or helpful to people or particular bias or something. So having these good sources. The other thing, just kind of in sort of the main original question also, and something we were talking about earlier made me think of, radiation, despite our great technology and sophistication and, we're getting better and better, there's just a fundamental that any of us, as we go into radiation oncology, understand very quickly is like the patient has to get there, like, and they have to get there every day for like weeks on end. So really,
Yeah.
the psychosocial, environment, everything that is around them is very important if you're going to have a successful outcome. My fanciest, radiation proton plan is only going to be successful if I can get the patient there every day. We can have them doing their bowel and their bladder prep correctly, preparation for treatment. We're sort of addressing all of the barriers to care that they may have or just kind of getting to us each day. And so that's where I think the community can help as well as sort of really making sure that patients have access, that they're getting to, and we have good care support teams and social workers and folks who can really try to help. It's far from my area that I treat, but we treat pediatric patients is very common. And, there's a whole team that child life specialist, social work, navigator, nurse. I mean, there's a whole team anesthesia to really make sure that we can get this one child, this one person like
Right.
on treatment and successfully through their radiation treatment course. So it really does literally take a village, in radiation oncology. And often we say, sometimes, you hear sort of for surgery, it's the volume, the outcomes, the volume of the surgeon is important. I tell patients, for radiation, it's the volume of the center, actually. How busy, the outcomes are usually tied to that. But it's because, yeah, it takes a whole team. It's not just the physician, it's the radiation therapist running the machine, it's the physicist calibrating and checking and ensuring the best quality, sub-millimeter precision, targeting the dosimeters, creating the radiation treatment plan, protecting the adjacent or working with the physician, the nurses, helping to guide the patient, through on your daily basis. So, I think that extends also beyond that immediate care team, but just again, those layers of how do we make sure patients are getting the appropriate management, getting to the center, and then having that successful outcome. And I think, unfortunately, when we see health disparities and poorer outcomes, often it has to do with just quality of care and access, and like that those things weren't being achieved. And so that's where I think we can, be our best advocates. The community can be the best advocates for an individual patient because it's hard when the patient themselves is going through this. So I usually tell patients, like, they'll say, they have someone with them or whatever. I say, we like to see that because it really does take a lot of support to make sure people get through treatment well.
You're right. And it's so important we tend to support people in, oh, like when somebody's having a baby, you come and you support
Hmm.
them in this. I think it's very
Hmm.
important that we do the same thing especially when it comes to illness like cancer. There's such a gravity to how it can change your life, even if it's for that moment. And
Yeah.
having a better understanding for ourselves so that we can maybe help ask questions or help take notes or help secure some patients. I think that's another thing is you made a lot of mention of how this is such a multidisciplinary kind of culmination to get a plan for one person. And the only thing I could think of was patience. Kept bringing patience and kind of understanding and communication, because I can see how that can get lost in translation. But having an understanding that there's a team of people really going to bat for you, and we need to have a level of patience. And I think that is something that I'm definitely going to take away from this conversation today, because
Good.
it's important. I don't think we give enough patience to our providers. And I also don't think that we collaborate as much as we could. So I always push to
Yeah.
being a collaborator, because it seems like there's so much work happening on your end, and for us to do the same thing, making sure we're securing good food, make sure we're securing positive energy space around us, because there's only but so much we can actually control. But I think good energy on our end can work with the good medicine on your end.
Yes. Absolutely, it all works together, and there's lots of evidence that demonstrates these kinds of things: well-being, spirituality, exercise, health, and well, all of these things, generally show positive outcome, better outcomes for cancer patients, less risk of recurrence, getting through the tolerability of treatment. So I think the more we can help patients to with reducing the stress and the burden and like getting them through treatment is to the benefit of them and to everyone else ultimately also.
Such good work. I have one more
Yeah.
question in the chat
Yeah.
before I have your wrap up question. Okay. So it
Yeah.
says it is commonly believed that side effects cannot be effectively treated, such as like loss of taste or swallowing issues. Is it true that they'll arise like chronic conditions, or in the process of treating radiation, can they be effectively solved?
It's a tough one to answer just because there are some side effects that will be permanent. That there are some changes depending on the type of cancer. Um, for example, if someone has a sinonasal cancer and they're getting surgery and radiation and chemo, you've altered the natural, function, there you're not going to have the sort of mucus clearance and those sorts of processes. But that's kind of an expected, side effect or complication, and there's ways that we can try to manage that for patients. So they may be given a regimen where they're, given drops or solutions or sprays and things that they need to do and maintenance. Um, and so there are things like that where there's some side effects from radiation that are just short-term temporary and go away and don't come back. And then there are others which are just, consequences of the treatments. And again, it's hard when the person's had surgery that some of these sort of just all overlap. Like the sarcoma patient, very often the most common site is the extremities, so in the muscle, and so they have surgery, or they have pre-op radiation, they have surgery, and so afterwards, we're meeting with the patient and we're telling them, rehab becomes most important now, where to make sure they're not having scar tissue, fibrosis, stiffness, loss of range of motion, joint. And if it's, if they're not proactive over the course of months or years, these things become irreversible and they may have a frozen joint or stiff joint or things like that. And so, we have to be proactive with, yes, trying to manage it and doing the things that, physical therapy. So there'll be sort of programs of sort of post-hab or that, rehab, like I talked about. Now we even think about prehab in certain disease sites where what are the things I can do ahead of time that sort of prepare me so I don't have these issues down the road? How do I minimize, say, cognitive risks and dysfunction or, other things to sort of preserve erectile functions? There's something I can do ahead of time that can preserve that. So I think the bottom line is good to have. It's a great question to sort of patients and family members, caregivers, like again, when you're interacting and thinking about treatments, ask, that's a fair question to ask. Hey, what can I do to try to minimize long-term risks? Is there something I should be doing now in terms of these side effects that you just went through, these, calculated risks that you just went through?
As a
Yeah.
public health professional, I
Yeah.
love prehab.
Yeah.
I love
Yeah.
the concept
Yeah.
of what can we do to prevent even
Yeah.
going down that road. I love
Yeah.
that concept. And I think I might steal it a little bit, prehab.
Yeah.
Um,
Definitely.
so
Definitely. There's a
finally,
whole evolving literature around prehab and cancer management and stuff. So yeah, I encourage,
it sounds
please.
like
Yeah.
a great thought
Yeah.
process to kind of
Yeah.
get people in the right mind track. So
Mhm.
definitely gonna look more into that. And so as we wrap up, because we are coming up upon the 7 o'clock hour, what do you see as the future direction for radiation therapy, and how can the community play a role in supporting these advancements?
Well, definitely the evolving technology. I think it does get tough where technology is expensive. And so how do we ensure that all communities, everyone has access to the same, high quality and high levels of technology? So I think, from that level, health policy, sort of higher level, we can advocate and ensure, what are the things that we can ensure bring people access to the great technology. And it's not just sort of certain groups or certain locations that have access to our advancements. Because that's fundamentally, I think, a core of radiation treatment, and our treatments can get better, but we want to make sure that, everybody is benefiting from those advances. And, even just talking domestically, but globally, there's a whole campaign around, there's many places in the world where the radiation is not available. And so you have much higher rates of cancer progression and, the cure rates and things like that, that could be, not completely solved, but like so much more improved if we improved access to radiation oncology, even globally, in terms of equipment, machines, facilities, staff, human resource, things like that. So, advocating is great to highlight radiation even on this platform. So, the advocating that all that radiation can do, because we don't necessarily hear so much, or there is some sort of mystique or mystery around it sometimes. And because yeah, I think there's just more to come in terms of those advancements. And to me, what drew me to radiation was this idea that, you can cure a patient without even sort of physically needing to like touch them. Like external radiation is just going in the body, targeting that tumor. Just the idea of that. And there's just more technology evolving in that way to continue to do that better and better and protecting. And that's more of the future of radiation oncology. And we're also getting better at delivering our treatment more efficiently. Like I was talking about before, not needing to come in 6, 7, 8 weeks, coming in 3 weeks, 4 weeks, a week and a half, and getting the same outcome. So we're getting better at doing that and letting people, maintain high quality, high function, even though they're diagnosed with cancer, right? I hear that from patients. I'm very happy when I hear that. Like people surprised and talking, they're just like, wow, you're going through radiation now? I'd never know. They're at the gym, they're exercising, they're
Yeah.
working, they're doing all these things and able to maintain that. And so that's the plug for radiation in terms of the benefits and the kind of future directions that there's still more and more to come. Yeah.
That is a great note for us to end on. I greatly appreciate your time that and your expertise and knowledge that you've been able to share with us. I hope that we were able to help somebody today and expand your understanding of radiation therapy. And if you have any questions, please feel free to email our Kimmel site and I will reach out to Dr. DeVille and see if we can get an answer if needed.
Yeah.
And then last question, completely unrelated from the topic. It says, you mentioned PIN. Did you know David Servin Schreiber?
I did not, unfortunately. Maybe I missed them in passing and was beyond my or outside of my area of expertise. But a lot of great folks, just like Hopkins, a lot of great folks. Yeah.
Yes. Well, thank you once again. We so appreciate it. Everybody on the call, please be on the lookout for the recording either tomorrow or Friday, along with the resources that we discussed in our call today so that you guys can have more information and share it amongst your networks. Again, everybody have a great night. We will see you next month, February 11th, for Ask the Expert.
Thank you so much. Bye-bye.